Hi, everyone. I'm David Miklowitz. I'm very happy to be able to talk to you about our study of clinician training in family-focused therapy, our treatment for kids who are at risk for bipolar disorder or psychosis. Let me start off by pulling up a couple of slides here. And this paper, which has just been published in Family Process. The goal was to see if we could take our family-focused therapy model, which is 12 sessions long over 4 months and intended for families of adolescents and young adults with mood and psychotic disorders. What was the most cost-efficient way of training community clinicians in this kind of therapy? We figured that the model for most training is to have a weekend workshop, which is quite a time investment, usually followed by weekly supervision on a training case. We decided we would compare that to a less intensive form of training based on webinar and less intensive supervision so that it might be scalable in the context of very high volume community mental health centers. The goal of our study was to determine whether the intensity of training of clinicians had an impact on their level of fidelity with the model itself and also how patients did over a brief time period, 4 months in this case. The design was a randomized controlled trial. We had 47 clinicians from various Los Angeles County mental health centers who either got high intensity training, which we defined as a 6-hour live workshop with lectures and slides, followed by telephone supervision after every session for their training cases. The low intensity group got a 4-hour webinar with the same content, but without a lecturer there, just based on a webinar, and phone supervision every 3 sessions for training cases, which we thought was a little closer to what might be scalable in a community mental health center. Our first finding was of these 47 clinicians, only 18 actually took on a training case after the training. That was in part because they were also involved in many other trainings at the same time or had very high clinical caseload. So we were limited to the people who could take on a training case. But within that subgroup of 18 clinicians, it didn't matter whether they got high or low intensity training. The patient attendance was very comparable, and fidelity scores done by an independent rater were also very comparable, whether they got live workshop plus more intensive supervision versus a webinar with less intensive supervision. But interestingly, the families still showed reductions in conflict over that 4-month treatment period, regardless of the level of intensity of the training of the clinicians. So interestingly, the best predictor of whether they took on a training case was the number of hours that the clinician already spent doing family therapy in their practice. So being a family therapist, in other words, made it more likely you were going to be willing to experiment with a new method. But whether we talked about psychoeducation, communication training, problem solving, or directiveness, the components of FFT, there were no differences either in fidelity to those components or in patient outcomes. So in conclusion, it appears that clinicians learn FFT just as well with an online workshop and less intensive supervision. This may suggest that dissemination of FFT is feasible using brief methods, but nevertheless, we know that community mental health centers are going to need to give their clinicians release time to be able to learn these and other techniques, since there is a certain amount of time that goes into supervision, taping of sessions, so a supervisor can listen to them, getting used to the model. So there are adaptations that need to be made. But most importantly, I think our study is showing the importance of an academic community partnering, the importance of university-based researchers like myself partnering with community mental health centers, designing training programs that work within the setting and the limitations of those settings, partnering with clinicians, giving them supervision that can fit within their schedule with encouragement to stick to a manual. That may be one way in which we can enable treatments like FFT shown to be effective in laboratory settings to be taken up in community mental health centers, hopefully to the benefit of our patients. Thank you for your interest in the article, and I wish you well.